Hello, my name is Eddie, and today I will be presenting a case study on a routine sinus case at Kern Radiology. Our patient is a 36-year-old female with a chief complaint of headaches and pain to the right side. She says that these headaches have been happening for around 4 weeks, so we had an order to do a sinus exam. The sinus exam at Kern Radiology includes a water, an AP Caldwell, and a right lateral, or a lateral depending on which side the pain is more prominent. The physician's findings were ready at the time of the exam when I acquired the radiographs. There was no acute fractures, no sinusitis. The only thing that the radiologist found with the exam performed was that there is slight deviation to the nasal septum, that it's deviated to the left. And let's get started. Oops, all right. Here we have a PA Caldwell, and here is our film. It is marked PA, annotated PA, and it is also marked to the lateral aspect. The collimation is open. They told me that they like to have everything open in case of incidental findings, which I found would be okay, but a little bit counterproductive due to the fact that we're just focused on the sinus, and you can probably fit this on a 5x5, but as per site protocol, they want it, they got it, I'll do it. This is a Waters, and this is obtained with a horizontal beam. Due to the sinuses and the nature of them, that we need to record the air fluid levels. These radiographs were taken on a Carestream digital. The patient was seated, and for the PA, we made sure to to align the OML to the image receptor, and then tilt the patient 15 degrees so that the Petri ridges would appear on the bottom 1/3 of the orbits, and their central ray would be exiting at the nasion. This I would collimate this, but they liked it open, so we kept it open. As you can see here, our ethmoid sinuses behind there would be our sphenoid sinuses. We can see faint outlines of our frontal sinuses right there. We can see the mastoid air cells and the Petri ridges right here. Oops, there's my finger. We can make sure to see maxillary sinuses as well, right here. Okay. This was used, we AEC it with a small focal spot, but if it were to become a manual, due to the ion chamber disconnecting as it often does, I would be using a technique at 40 inches, 75 kVp at 12 mass. The patient was okay. They didn't have any trouble walking, so no immobilizations were used, and the patient was able to keep still, so there was no adaptations. And this is a proper Caldwell because we can criteria. It was a horizontal beam, and we see the Petri ridges in the lower 1/3. Go on to the right lateral. The lateral was also they also told me to keep everything open due to they want to see the airway and everything that is visual there. We marked it to the right side closest to the image receptor. The technologist on board asked the patient questions, and they didn't have a specific side that they were going to examine until I went in, stepped in, and I had to ask the patient, and she said that she was having pain on the right sides, more prominent, so I made sure to take a right lateral to demonstrate the side down. We can tell that this is a true lateral by having the intrapupillary line perpendicular to the image receptor. We would be using a horizontal beam, and it would be our centering point would be halfway between the outer canthus and the EAM. I probably could have brought her a smidge down to have the IOML parallel to the board, but this did not warrant a repeat, as we can see all the 4 sinuses, which would be the frontal, the ethmoid, the sphenoid, and the maxillary sinuses, all in question and all in profile. You can also see the sella turcica right there in the perfect lateral position. The EAM, our occipital or frontal bone, occipital bone, temporal bone. We can even see the cervical spine here, mandible, gonian, alveolar process, teeth, and we can even see the soft tissue structures, which would also demonstrate that we had great contrast. We have good contrast, as we can deviate from between sharp bony margins, demonstrating that there's no motion, to the soft tissue structures. So we have good contrast and decent density that we were able to tell everything apart. This is marked lateral, or this is marked in our light field, just to make sure. The patient was upright. They were just seated down, but everything is upright with a horizontal beam. And in any other place that would not require such open collimation, 6x6 or maybe in a 5x5, we could all fit all the sinuses, since it does keep them all in profile. And here we have our PA Waters view. This was marked PA, annotated PA, left marker to demonstrate the left side. Here is actually a bit of a problem. The tech accepted it and said that it was fine due to the fact that there would be no gross swelling. And we see the orbits enlarged, demonstrating those PEA. If it was AP, these orbits would be magnified. We can see the frontal sinuses in clear view with good contrast to the more other bony anatomy that does not have sinuses. We can see the ethmoid sinuses here, the maxillary sinuses. The only problem that would warrant a repeat, but it was okay, we can see the mastoid tips, but the thing that if this image were to be repeated, I would make sure to tilt the chin up on the patient just a bit more, because the petrous ridges, the maxillary sinuses aren't completely above the petrous ridges, but they are very clearly in pictured. The patient was shielded with a waist band of lead, and to make sure that we are LARA compliant. And this I would honestly probably even tilt patient right just a little bit. Here is the slight deviation that the radiologist found. It does deviate to the left just slightly. Probably all the techniques for this one would be a small AE or AEC with a small focal spot as well, or 75 at 12 mass. We have great contrast with every single of these images that we are able to tell. We have a long scale of grays. We have good density, and we are able to tell bony anatomy from air-filled cavities and sinuses. So these all are great examples of good contrast. And for sinuses, we would all make sure that we always have a horizontal beam to judge for air fluid levels. And I believe that is all the points that I have covered. Except for the central ray on this one, we would make sure to have the MML perpendicular, and we would exit at the acanthyon. And I believe that's it. That one we'd exit at the nasion after tilting the patient 15 degrees cephalically. Okay, and that is everything. That is my case study for the week.